So how common is hydrocephalus? Like we don't have population-based studies from our country, but from US, it is like 0.2 to 0.8 per thousand live births. And common is congenital hydrocephalus. And commonly known pathologies among congenital hydrocephalus like Dandy-Walker malformations or associated with myelomeningocele or IVH, for which we have a separate session later. And among the survivors of meningitis, as pediatrician you see a lot of meningitis, but 1% of these children can develop hydrocephalus later. And head trauma, though it is not so common cause of hydrocephalus, but currently because of aggressive treatment, many children are surviving, and they are surviving long enough. So as a sequelae of traumatic brain injury, they develop hydrocephalus later during rehabilitation. Genetically, X-linked hydrocephalus is a very popularly known entity among pediatricians, particularly in males. In posterior fossa tumors, more than 80% children, they present with hydrocephalus. Actually, they present with hydrocephalus rather than any other neurological signs and symptoms. And nearly 1/3 of them may have permanent hydrocephalus even after successful removal of tumor and even after radiotherapy and chemotherapy. And children with complex craniosynostosis, syndromic craniosynostosis can also have hydrocephalus. So it is more common in African continent, and there is a reason, like hydrocephalus is, as I told you, it is more commonly associated with spina bifida, and which is also much more common in Africa as compared to other continents. And within Africa, in Uganda, there is infection, there was like epidemic of infection of Penibacillus suppurativa infection in a cluster in Uganda. So there was an epidemic of hydrocephalus. So this infection usually occurs in mother in the perinatal period. So children born to such mothers or children themselves sometimes get infection immediately after birth, and there is a huge incidence of hydrocephalus in some subsection of Uganda. So hydrocephalus, we all learned in MBBS, there are only two, communicating and non-communicating, or we call obstructive and non-obstructive. But it is too simple classification of hydrocephalus. Actually, it is a continuum. The blood goes from the heart to brain through choroid plexus and other sources to ventricles, then goes to the venous sinuses, and then comes back to the heart. This is what we learned. But there are many other pathways through which CSF can form and CSF can go. And any obstruction, like virtually actually all hydrocephalus is obstructive. There is an obstruction somewhere. That's why the CSF does not get back into the venous circulation and hydrocephalus develops. For example, in this picture I have shown, it is like a continuum of pathology which can cause hydrocephalus. So these are the classical 8 examples, like one is arrested hydrocephalus, like there is hydrocephalus but no raised ICP. That is because arterial pulsation problems. Whereas aqueductal stenosis, tumors or cysts, they cause major obstruction in the CSF circulation pathway and cause hydrocephalus. Whereas post-hemorrhagic hydrocephalus usually occurs due to poor CSF absorption at the arachnoid villi. And venous congestion, for example, sometimes in craniosynostosis, that can also cause hydrocephalus. So in this current era of neuroimaging, and particularly in Bangalore, where there are more number of CT scan centers and neurologists and neurosurgeons than pawn shops, we will never get an opportunity to learn the natural history of hydrocephalus anytime now in our lifetime. So this is a landmark paper which was published in your pediatric journal, Archives of Disease of Childhood, on natural history of hydrocephalus. So this is from 3 hospitals. 182 children were, 182 children were followed up without undergoing surgery. They followed up to 15 to 20 years to know what happens to these children if they do not undergo surgery. So you can see as time goes on, the children die. So hydrocephalus is a fatal disease. So by end of 1 year, only 80% would have survived, and by 15 to 20 years, only 20% of these children survive. So that's what happens if you do not treat hydrocephalus. So let's do quickly a wake-up test. I hope all of you are awake. So this is awakening scale of students who are attending my class, and I hope that all of you score 15, at least 14 or 13. And if it is 13, I will shout, you can make it 15. Okay? So natural history, like it goes in 2 pathways. Like if you do not do surgery, the head becomes big, big, big. So there is a condition called extreme hydrocephalus, where the head circumference exceeds the length of an infant. So head becomes much big. It looks like a tennis racket. The child, the first case, like you can see, it looks like a tennis racket. This is called extreme hydrocephalus. So these are the pictures from our hospital. And extreme hydrocephalus is a fatal condition. Like even after successful treatment, 1/3 of our children, they died, and only one survived and had some developmental milestones. So this is what happens if you do not treat hydrocephalus timely. What happens? Few lucky children, roughly after 3 years of age, the head does not become larger anymore, and they go on to develop what is called as arrested hydrocephalus, like this particular child. Now he is now 5 years or something, and when he was an infant, the prognosis was so badly explained to the parents, they thought anyway child will die, no need of surgery. Luckily or unluckily, whatever you may say, the child did not die, and now child has come with a huge head. So these are the 3D models of two children. One is normal and another is now because of increased awareness and accessibility, the parents have come to us for reduction cranioplasty. So had this child undergone surgery during infancy, he would not have reached this stage. So this is what happens, like if the children do not die, nearly 15 to 20% or something like that, they will develop arrested hydrocephalus and the head size does not increase further. There is a compensation between CSF formation and CSF absorption. The axonal stretch occurs, and which does not allow further CSF to form, and that's how it gets arrested. But what happens to these children whose hydrocephalus get arrested? Most of them, nearly 50% of them, do not have normal IQ. So, and nearly 1/3, they are not educatable, means they cannot go to routine school. So this, like white panel is normal, IQ of normal population, and shaded is abnormal. This is from the same paper of 1962. So that's why surgery is required. So surgical treatment, there are many types of surgical approaches, like temporary surgical treatment is required for children with unfavorable CSF or unfavorable age. These are the classic examples of perinatal hemorrhage, that hemorrhage of prematurity, which we have talked later on. For them, you can do serial lumbar punctures, you can put external ventricular drainage, you can put ventricular access devices, what is called catheter, and connect it to subgaleal reservoir. And sometimes some of the people do, though we do not do, there is something called ventriculo-subgaleal shunt, like you put a catheter in the ventricle and keep the free end of the catheter inside the subgaleal space, make a pocket. So these are some temporary measures which can be done. And for children with ventriculitis, you can do neuroendoscopic lavage. So these are the temporary measures before definite shunt can be inserted. Now shunt, classically we insert ventriculoperitoneal shunt, and sometimes if peritoneal cavity is not congenial, then you can put in atrium. You can put even subdural. These children are vulnerable to develop subdural effusions. Subduroperitoneal shunt is also there, and lumboperitoneal shunt for few children with communicating hydrocephalus. One is endoscopic, and shunt is required in case of post-ventriculitis, where neuroendoscopic lavage is done, and after that shunt can be placed. And in case of multiloculated hydrocephalus, which occurs after hemorrhage or after ventriculitis, then endoscopic with shunt can be done. And sometimes a stent can be put across the aqueduct, so that fourth ventricle, if it is isolated, it communicates with rest of the ventricle and add it to the VP shunt. Pure endoscopic procedure, endoscopic third ventriculostomy is the classical procedure. We can add the choroid plexus coagulation, and biopsy of the tumor can be done if it is obstructing the pathway, and cyst fenestration can be done, and cyst collapses and CSF pathway opens. So this is what we do in endoscopic third ventriculostomy. We make a burr hole in front of the coronal suture, right frontal classically, go all the way to third ventricle, puncture the floor of the third ventricle so that CSF from ventricle goes to the basal systems and starts circulating. And additional procedure is choroid plexus cauterization. So this was popularized by African neurosurgeons. So they take flexible endoscope and cauterize the choroid plexus, like both right and left, they go through the septum and do that. But somehow choroid plexus cauterization is not so popular. ETV is popular, and there is a success score. We can predict based on the ETV success score whether ETV will work or will not work. Regarding choroid plexus cauterization, like these are my personal views. Some people may be practicing over here, and worldwide also some people practice. Like it's like two kidneys. We have two kidneys. If you remove one kidney, the other kidney will form as much urine. Similarly, if you nearly 80-90% of choroid plexus also you cauterize, whatever remnant choroid plexus, you cannot cauterize entire choroid plexus. Like Dandy in 1920s or something, he did choroid plexectomy, like he removed both choroid plexus, still hydrocephalus occurred. So it's not a very popular procedure, but some people feel that if you add this choroid plexus cauterization along with ETV, so temporarily some CSF reduction can occur and wound can heal, and by the time child may become little big and ETV stoma may start working. So problems with VP shunt is shunt malfunction. So this is one of from paper about 10 years old. Like if you follow these children for long enough, this was 15 years study. So at the end of 10 years, nearly 85% shunt would have failed. Now there are few neurosurgeons who may disagree, like they may boast that I do shunt, it never fails. So what happens when shunt fails? There are two aspects. If shunt fails, parents do not want to go to the same surgeon again for shunt revision because they thought this surgeon is bad, my shunt failed. He goes to another neurosurgeon. That neurosurgeon does not want to operate, does not want to revise the shunt. He says, why should I revise the shunt? Placed by somebody else. So because of this, after an index surgery, a surgeon never gets a long-term follow-up of the shunt he has placed. So this was the study which showed single surgeon, he followed for 15 years and he found that many shunts fail. And you will be surprised to know if you put a shunt during infancy, 2.5 times revision will be required by the child becomes adult, and 5% may require up to 10 times revision throughout life. So what is the option? Whether we can use an adjustable valve so that shunt does not fail, shunt does not overdrain, subdural hematoma does not occur, etc. So yes, adjustable valve is good for adult hydrocephalus, but for children, whether you put adjustable or fixed pressure, the outcome is same. Another problem with shunt is infections. So infection rate in 2/3, this is a global survey of all the continents. So 2/3 of the institute reported that infection rate is less than 5%, whereas 1/3 reported that infection rate is more than 5%. Though we have strict shunt protocol, still infection is inevitable. And infection occurs, then you have to remove shunt, you put EVD, you give antibiotic, wait for 1, 2, 3 negative cultures, and before you put next shunt. So shunt infection is a really nagging problem. So what is the answer? Is antibiotic impregnated shunt an answer? Though it is widely used in Americas, but not so much in Asian countries or other countries. So this is the latest systematic review and meta. Every year if you go, one systematic review on antibiotic impregnated shunt will come because one study will come every year. So based on the observational study, this authors conclude